But I have a little bit of an aggressive agenda. I shared that I've got several stops in my talk, so wherever we get to is where we'll get to, and I'll kind of pick one of those stops and try to leave 5 or 10 minutes at the end for questions. So just so I know what the crowd is, how many are medical students here? Okay. How many are residents? Okay. And how many are faculty? All right. Very good. So we're going to talk about just a number of different topics in pediatric otolaryngology. I'm sure you're exposed to a good bit of this. We'll dive maybe a little deeper than you normally might get in a general pediatric setting. Some of you, this may be in your wheelhouse. Others, it may be a little bit less common, but we'll just go through it. And if you have questions as we go along, feel free to raise your hand. If not, there'll be a time at the end for you to ask questions, and I'll stick around afterwards for a few minutes as well. So this is kind of what we're going to try to go through. Probably where the red line is probably where we'll end up stopping, maybe even after Stridor, depending on if we how deep we dive into some of this. So hearing loss is the most prevalent developmental abnormality at birth. It's about 2 to 3 per 1,000. The next most common is Down syndrome, which is about 1 in 600 or 700. So hearing loss is about 1 in 300 or 350. About 4,000 children each year that are born deaf, 37,000 with milder forms of hearing loss. And this has been a big win for all of us in the pediatric world that deal with children with communication disorders, and that is universal hearing screening. It just is standard fare for those of you that are medical students and residents, but it hasn't been standard fare forever. So in 2008, Clare's Law was passed in Tennessee, and universal newborn hearing screening is happening. It's been a success. We're over 95% at screening children at birth now in the state of Tennessee, maybe even inching a little bit higher than that. The problem with that is 28% of the children that have hearing loss identified don't get any documented follow-up. So it's great that we're now screening. The key is now that once they get out of the hospital as a newborn, that they get the follow-up that they need. And then beyond that, for every 10 children that are identified with hearing loss at birth, there's another 5 to 9 children who will manifest hearing loss by the time they're 9 years of age. So they acquire hearing loss after they're born. And in fact, that about 50% will have passed their newborn hearing screening for those that have significant hearing loss by the time they're 9 years old. American Academy of Pediatrics has an aggressive protocol for hearing screening for children in early childhood and adolescence, and then recommend hearing screening for newborns to be screened initially, and then repeat that at 4, 5, 6, 8, and 10 in the office. So a lot of you will be doing that if you go out into clinical practice on an outpatient basis. Those are things that you will be doing as part of your practice. But about 10% of children don't get that screening. So that's something that we've got to shore up to ensure that they effectively get screened and then get referred properly so that that screening abnormality can be determined. Am I messing with you walking around? Okay. I see the camera there, and I'm like, if I'm walking over here, he's going to be projecting to people this blank wall behind me. So what should we do? Well, we really kind of need an all-of-the-above approach to this, in the sense that we need newborn hearing screening, we need well-child hearing screening, and then when they're abnormal, we need to make sure that follow-up and rechecks happen to ensure that they get effectively intervened. It takes a lot of people working together to make this happen. It takes hospitals and birthing centers. It takes neonatologists and perinatologists. It takes pediatricians and family practitioners in the community. And then it takes pediatric audiologists and biased pediatric otolaryngologists. Obviously, there's general otolaryngology, which you have ample access to here. And then at other tertiary centers, there are pediatric otolaryngologists that all we do each day are just take care of kids. The goals nationally are to identify or screen all newborns by a month, then by 3 months confirm their hearing loss with a hearing test beyond the screen, and refer for otolaryngology assessment and intervention by 3 months, and then try to get them involved in intervention services. We're blessed in Tennessee with TEIS. Those of you in practice are familiar with it, Tennessee Early Intervention Service. It's free for families until they're 3 years old, and they will come to the house and do an assessment, and then they'll get speech therapy involved with these patients that have hearing loss and assist with their speech development. So if we confirm that there's a hearing loss at newborn hearing screen, then that means we need to do, what do we do for follow-up? How do we recheck them? Well, we want to check them every 3 months from birth to 3 if they have a hearing loss, from 3 to 6 every 6 months, and then annually after 6 years of age to make sure they're not having progression or worsening of their hearing loss. For the ones that pass on newborn hearing screening but are high risk in some form or fashion, then they need to be retested about 6 to 9 months of age when visual reinforcement audiometry can be done, and I'll touch on that in a minute. It's a diagnostic testing modality. And then for higher risk, every 6 months, lower risk annually until 5 years of age. These are the things we should not say. These are things that are accidentally said to many families in the NICU or in the well baby nurseries, and that is, well, I'm sure he can hear okay. Most babies pass the rescreen. It's always just fluid. It's probably not a big deal. Everybody wants to try to make the family feel okay about it, but in the end, we got to make sure they get followed up. And if we diminish the significance of the failed hearing screen, then that may diminish their follow through on getting that checked into afterwards. So let's talk ear anatomy and functioning a little bit. 3 components to the ear: the outer ear, the middle ear, and the inner ear. Types of hearing loss. Historically, we've divided hearing loss into conductive hearing loss and sensorineural hearing loss. Since we have had otoacoustic emission testing, though, that allows us to test cochlear functioning individually. And so now we actually more correctly divide hearing loss into conductive hearing loss, sensory hearing loss, and neural hearing loss. So neural hearing loss would be an auditory neuropathy where there's a problem with the hearing nerve itself. Whereas cochlear dysfunction, a sensory loss, the conversion of sound into an electrical signal, occurs in the cochlea, and an abnormality there would be considered a sensory loss as opposed to a sensorineural loss. You won't be considered wrong if you continue to call it sensorineural, but when they get in our hands, we're going to try to divide that and do placement testing on where that hearing loss is occurring. How do we describe it? We describe it as we just discussed, as well as was it congenital or acquired? Is it unilateral, bilateral? Is it symmetrical? Is it asymmetrical? What's the severity of it? And then what's its character? Is it stable, staying the same? On each of those checks, is it staying the same? Is it worsening, or is it fluctuant? Rarely is it fluctuant and goes in a positive direction. So it may get better, but then it usually gets worse. And then the trend is downward, typically with a fluctuant hearing loss, if there's a dynamic in play there. It's rare that we see patients that start with a bad level of hearing and get better over time. Causes. 50% of hearing loss is genetic, 25% acquired, and I think probably we will see that this other will eventually be more genetic than we've discovered as the Human Genome Project progresses and we identify more genes that are associated with hearing loss. Connexin 26 is responsible for about 1/3 of all the genetic hearing loss that exists out there, and it's a pretty big number as you gather. Half of all non-syndromic hearing loss is Connexin 26 related. Connexin 26 is a protein found on the GJB2 gene. It's the most common cause of congenital hearing loss, and it manifests itself typically as severe to profound sensory hearing loss. It can be mild to profound, but usually severe to profound, and actually this should be sensory hearing loss because it's typically a defect within the cochlea, and the defect has to do with these gap junction proteins, which are necessary for cells to communicate with each other. And what happens in these patients is they get high levels of potassium in the organ of Corti, in the cochlea. And so that high potassium causes dysfunction, cochlear dysfunction, and thus hearing loss. So let me take you back just for a second here to this. So this is how I describe to families the hearing process and hearing dysfunction. You might think, well, this is fairly rudimentary, but I think it helps conceptualize things. So if you think about sound in the air, you think about you listening to me right now, there are sound waves going around this room, okay? And those sound waves come in and strike the eardrum and create a vibration. Sound waves become a vibration, still physical sound. Physical sound is transmitted from the eardrum, from the tympanic membrane, through the malleus, through the incus, through the stapes, to the oval window. Still a vibration, still physical sound. At the oval window, the vibration from the tympanic membrane is transferred to a smaller membrane at the oval window, and that creates a ripple, if you will, in the fluid of the inner ear, in the cochlea. And that ripple is still a physical property. There's movement of fluid as a result of vibration, as a result of a sound wave. So you still have physical sound, but what happens at that point is the hair cells in the cochlea get deflected. The outer hair cells primarily affect loudness. The inner hair cells in the cochlea primarily affect pitch. And how far the ripple goes and which hair cells get deflected determine what you hear. So the basal turn of the cochlea affects mainly low frequency sound. The apical turn of the cochlea is high frequency. I'm sorry, reverse it. The base is high frequency, the apical is low frequency. So the injury that occurs with noise-induced hearing loss occurs more with high frequency sounds in the basal turn. But what happens is those hair cells get deflected and they convert the physical sound into an electrical signal. That's where the action happens, okay? And that's where connexin 26 comes into play, because the gap junction proteins, you get this potassium buildup and it causes dysfunction of the cochlea, and you don't get the conversion of physical sound into an electrical signal. So in patients with connexin 26 defects, the hearing nerve is still there. The hearing nerve still works. The auditory cortex in the brain still works. It's just that the cochlea doesn't convert physical sound into an electrical signal that can be utilized by the patient. Does that make some sense? Okay. Sorry to backtrack. So for connexin 26 patients, it's an autosomal recessive pattern, so 25% of patients will have a deaf child, 25% of those parents who have the trait will have a deaf child, and 2/3 of the siblings will carry the mutation. Lots of different causes of hearing loss. We've talked about some of these. Acquired causes, infectious causes primarily, but also noise-induced that we've mentioned, hyperbilirubinemia that we deal with in newborns, and some others that aren't quite as frequent, but you see the list there. So indicators, what do we look for to determine if hearing loss is a possibility? What makes us more concerned? Being in the NICU more than 5 days, low birth weight, hyperbilirubinemia that we've discussed, ototoxic medications, which is why we do all of our blood levels on aminoglycosides and other medicines that can be toxic, APGARs that are low, syndromic children, ventilation or ECMO, family history. There's just a number of different things that can make you a high-risk patient in the newborn nursery. Are y'all seeing and hearing me okay? I feel like I'm just blocked here. I keep walking around. I hope this isn't distracting for y'all. But I'm using my pointer over here. I can't do it over there for y'all. So maybe you can see around the corner. So this is a big point. It's faulty to think that parents can observe behavior and determine if their child has hearing loss or not. So it's a high false negative if you think of it. Now, if parents recognize their child has hearing, it's probably pretty significant. But if they don't recognize their child has hearing loss, it shouldn't bring great confidence. So That's why the screening tests are so important in the pediatrician's office. So don't underestimate the value of the parental input, but don't rest your hat on it either, okay? So a hearing loss workup, what do? We do the typical things that you're taught for the medical students that are here. You want to do a good history and physical examination, but as in concert with that, you're going to do your hearing test and do a definitive test to determine if they have hearing loss, and then you're going to go, if there is a hearing loss, you're going to look into other things. The two things in red, the MRI and the Connection 26, might be the bare bones workup for somebody that has a sensory or sensorineural hearing loss. Some would argue that's all you need. Typically, when I do a hearing loss workup, I'll get especially if it's a patient that's being considered for a cochlear implant, we'll do a CT scan of the temporal bones because I can see bony structure of the temporal bone much better with that than I can the MRI. And then we'll do other selective lab testing in addition to the MRI and CT beyond the genetic test. How do we measure hearing loss? So this may get into a little bit grayer zone or foreign to you, so we have behavioral testing, and amazingly our audiologists can do hearing testing down to 6 months old. So it's a conditioned response. So a child's in a hearing booth sitting in their parent's lap at 6 months old, and they'll condition them. So they'll do a sound, and we've got video screens in the room, and we can make whatever cartoon character or noise or whatever on this video screen. Kids are pretty alert to video screens and smartphones now. So we can present a sound and show a picture. And the child sees the connection. You do the sound and you show the picture. And once you've got them conditioned, then you do the sound and you don't show the picture. And you see if they look to tell if they're responding to that sound at that level, decibel level. So that's how you do behavioral testing. Then there's otoacoustic emissions and ABRs, which don't require child participation. If a child can be quiet, those can be done on a non-sedated child. More often than not, for a child that we need definitive testing, we'll do the OAEs, which doesn't require sedation usually, unless the child just screams bloody murder the whole time, in which case you might do it in concert with an ABR. But an ABR is an auditory brainstem response test. The easiest way to explain this to you is that an ABR is basically measuring brain waves in response to sound. So we introduce sound into the ears. We can do ear specific, so they have headphones on or ear inserts in place, present the sound, and then you take the artifact out of the brain waves that you measure, and you look at the brain waves that are specific for auditory functioning and can determine what the child's level of hearing loss is. You can tell if it's sensorineural or conductive because they use a bone oscillator on the skull to introduce the sound separate from air conduction. And so it's the gold standard of hearing testing in children. It's what we would always do in a child that's young before making a big decision about cochlear implantation or other things like that. What determines level of hearing loss? Well, normal hearing is about 0 to 20 or 25 decibels. Mild hearing loss is 25 to 40, moderate, moderately severe, severe, and profound. Anything below moderate, especially if the child's not doing well with hearing aids, would be in a cochlear implant range to consider. More often than not, what we'll see is we'll see one side that's severe to profound and the other side that might have, maybe in the low frequencies, a little bit of preservation of sound functioning, but not enough to be useful. And so we'll often put the implant in the side that's severe to profound and let them use a hearing aid on that side. If they find the cochlear implant is much better, the cochlear implant will get their hearing up to about normal, almost, usually right around 20, 25 decibels, sometimes in the normal range. So if they're living down here at 80, 90, 100 decibels, then that's a significant improvement. So a lot of times what happens is we put one cochlear implant in, the moderately severe to severe side, they go, oh, this works so much better than this hearing aid, and they come back a year or two later and go, put one in the other side too. Others don't. Others are like, I like to be able to hear a little bit without any sort of device, and so whether it be a fire alarm or a phone ringing or what have you, they'll just keep the hearing aid in the other side. So we've already talked on this. I'm not going to dwell on it. I guess the one point I would make with this behavioral testing at a young age is In our institution, a lot of times we see a lot of pediatricians referring for sedated ABRs like on 2-year-olds or 12-month-olds. And a good audiologist can do visual reinforcement audiometry, can do behavioral testing in the office without sedation. And so that sedated ABR should not be your go-to first-line test for a child that fails their hearing screening in your office. They just need to see somebody and let them do OAEs in conjunction with behavioral testing, and that usually is adequate. But for the ones that are more complicated, then you may want to move on to auditory brainstem response testing. A lot of people involved in these children, because many times they're syndromic or have other things, you know, head, heart, hand. I don't know if y'all have learned that, but a lot of times syndromic patients or patients who have ear problems also have heart and hand defects, so you just want to look through. We'll see branchio-otorenal syndrome sometimes, so patients with branchial anomalies, branchial cleft cyst, preauricular appendages or skin tags, microtia, that sort of thing. You're going to look at the kidneys. You're going to do a renal ultrasound to make sure there isn't some other renal pathology in conjunction with their ear pathology, because those occur about the same time with embryologic development. How do we treat? Well, we use hearing aids primarily for sensorineural hearing loss that's of a lower level. We use medications, obviously, if there's a treatable problem. Sign language is clearly an option for a family that is ensconced culturally in the deaf community. Sign language may be their preferred route of communication for their child. More often than not, for parents that are hearing parents, if there's an option for a hearing child in the form of cochlear implantation, they choose that. But we don't want to overlook the fact that sign language is an option. Baha implants are a little bit different, and I'll deal with them in a minute, and then we'll talk about cochlear implantation a little bit more. How am I doing time-wise? About halfway through.
Because this is just your mic. Can you hear?
Can y'all hear okay?
Yeah.
Okay, good, good. So the cochlear implant, so we've talked about how we hear normally. So a cochlear implant, the way it works is, since the hearing nerve and the auditory cortex still work properly, with a cochlear implant, the sound comes in, and actually these implants now have microphones in multiple places, on the behind the ear apparatus and sometimes on the transmitter coil here. But there's an external device that's here, and then there's an internal device that's implanted, and there's a magnet that holds the coil to the internal receiver. So what happens in a child that has a cochlear implant is sound now comes in through the air, goes to the microphone on the external part of the device. The microphone picks up the sound, takes the sound to this speech processor that decodes it, takes the sound and breaks it down into its frequencies and its loudness and that sort of thing, morphs it into a presentable electrical signal, and then by way of the transmittal coil sends that through an FM signal to the internal receiver, which then transduces that sound through the electrode array that we've inserted into the cochlea, and then that presents this electrical input to the nerve endings of the spiral ganglion of the auditory nerve, and then that can then pick up the noise and take it to the brain. Okay? So if I were speaking Chinese right now, maybe some of you could understand me, I don't know, but most of you wouldn't be able to understand me. Or if I was speaking Portuguese or whatever, think about language. We've just learned to manipulate sound to communicate. I mean, I could stomp my foot, I could snap my fingers, and if we attached meaning to that sound, we're communicating, right? Okay? So one of the big questions of cochlear implantation is, well, does it sound the same? And the honest answer is no. Folks that have heard before, that we've had who've had progressive hearing loss, who lose their hearing, and then we implant them and they get their hearing back, initially say, oh, it's different. It's like Charlie Brown's teacher initially. It's like, you know, it's like robotic, kind of mechanical sound. But the cool thing about the brain is it's adaptive. And the brain morphs that sound. Those people that have heard before, that get implanted and then go through oral habilitation, hearing therapy, or rehabilitation if they've heard before, will tell us that mom's voice ultimately sounds like mom's voice again after a period of time. So the plasticity of the brain is amazing. So yes, it's different, but if you think about it, it's not exactly the way they heard before through a normal cochlea. It's a different type of sound, but the brain is capable of learning how to manipulate noise to communicate. And that's how the cochlear implant functions. There's a lot of research and development into how do you do better speech processing. There's a lot of competition between the cochlear implant manufacturers about what's the best way to decode speech and then transmit that, and they all market that theirs is better because their speech processing strategy is better and different little things like that. But the bottom line is there are 3 manufacturers out there that are all pretty good, that have successful outcomes. We use 2 of them, mainly just because in our office, just to keep up with the software and everything that you have to do with cochlear implantation, it's not feasible or worthwhile to do all 3. One of them's a European company, the other 2 are American, so we use the 2 American companies. We've already talked about this. This is just showing the components and the things that I referred to a minute ago. Who's a candidate? Well, in 1998, when I left Baltimore and the listening center at Hopkins and came to Knoxville, 24 months was the age, the FDA approved age for cochlear implantation. And then a couple of years later, it became 18 months. And then a couple of years after that, it became 12 months. So 12 months is the minimum age. There are some experimental protocols that are less than 12 months, or if you have meningitis, then we try to quickly, and you develop deafness as a result of your meningitis, we try to quickly implant afterwards because of bone growth into the inner ear. That's the one deviation from that. Severe to profound bilateral sensory hearing loss is the typical indication. One of the odd things is an auditory neuropathy where the hearing nerve is the problem actually benefits from a cochlear implant. And I don't know that we understand completely why that is, but there are some patients who have auditory neuropathies that actually on their behavioral audiogram, they may hear at about 40 or 50 decibels, but they can't use it. It's the dyssynchrony that's occurring from a neurologic perspective with their auditory nerve is not effective to allow for communication. So it takes a little bit longer to watch them and determine that it's not functioning properly, but they actually benefit from cochlear implantation. Hypoplasia of the auditory nerve or aplasia where there's no nerve. If there's no nerve, there's an auditory brainstem implant that can be done. It's more of a neurosurgical type procedure where they put an electrode on the brainstem, but they actually have found that if there is some small remnant of the auditory nerve, be it ever so small, they actually get benefit from a typical cochlear implant in many circumstances. Usually try to give them hearing aids. Want to make sure there's no medical or otologic contraindications. There aren't too many of those except for sometimes some dramatic dysmorphism within the cochlea. If there's cochlear dysmorphism or dysplasia, sometimes that can inhibit implantation. Medical contraindications, some sort of cardiac defect or something along those lines. It's rare that we run into things that we can't overcome, but occasionally that occurs. And then it's really important that these families have appropriate expectations. We live in a power-up world. We're used to turning on this and this and this and that with power buttons. And so when we put a cochlear implant on a patient, guess what the parents think? They think once it's in and a month later when I get the implant put on, boom, my child starts talking. My child starts understanding me. And you have to counsel these families, listen, you have to learn to hear. You didn't come out of the womb talking, did you? It took you about 12 to 18 months to start determining what sound meant and how to use it and that sort of thing. So the therapy afterwards is as important as the surgery itself. The other thing is the reason why we put hearing aids on leading up to 12 months of life is because there are trophic nurturing influences that occur from stimulating the auditory nerve even when they're deaf. And so that's why a patient doesn't do as well if they've been deaf for 12 to 15 years and get an implant versus a child that's been deaf for less than 1 year and gets an implant, because you get some atrophy of the nerves with non-use or minimal use. So there are cultural issues. The deaf community has historically been somewhat oppositional to cochlear implants, and I think it's always important to be respectful of that. When I came back to Knoxville, I went to the Tennessee School for the Deaf that's based in Knoxville and met with them. I met with the Center on Deafness at UT. I just wanted them to know that I'm not a surgical cowboy. I'm not here to implant every patient that has hearing loss. It's only if the family feels like that's the right thing. The problem is sometimes the deaf culture can overstep its bounds and try to impose its will on a family and suggest to a hearing family that would choose cochlear implantation that they should not choose that this child's birthright is the deaf community and sign language. And ultimately, it would seem, and there have been lots of debates, and this is sort of gets into medical ethics a little bit and that sort of thing, but it would seem that this is a family decision. It shouldn't be a decision that the deaf culture makes. It really shouldn't be a decision that a surgeon or a proponent of cochlear implant technology makes. It should be inform the family and let the family make the best decision for their child. But respect goes a long way, and I think we just have to respect the deaf community. So it's less of an issue. Dr. Naparko, who I trained with at Hopkins, actually implanted the head of the National Association for the Deaf about 10 years ago. You've got some prominent folks. Miss America was implanted. Rush Limbaugh was implanted, whether you like him or not. He said, think about it conceptually. A guy that's a radio talk show host who can't see his audience to read lips or body language is able to have a viable broadcasting business to do that. It's pretty amazing that you could do that. So it's a technology that is quite rewarding to be a part of, and it's something that hopefully having some insight to will help you as you encounter these children in your practice occasionally. So we usually see them early, follow up, and then schedule their surgery usually around 12 months, activate them after 1 month, and then it becomes an aggressive therapy program, basically hearing therapy instead of speech therapy, which is a little foreign, but basically it's a variation of speech therapy that allows them to optimize their hearing. 3 parts to it. You have to make sure you've got a good candidate, you've got to do surgery well, and then you've got to do therapy well. If you fail on any of these 3 things, the implant will not be as successful. This is a cochlear implant wound. There's an incision that's made behind the ear. This is the facial recess. The facial nerve runs right down through here. And so facial nerve injury is a risk. I've never had it happen in 20 years. But it's a theoretical risk with every patient. We use a facial nerve monitor during the case. That's the thing that sticks out to most people, because if you ding the facial nerve, your face is paralyzed the rest of your life. But that's a very rare occurrence. I don't know of a patient that has it, but if you're not cautious, you can run into it. As soon as you stop worrying about it, you probably are going to have a problem with it. This is the internal receiver, and the electrode going into the facial recess goes down into the middle ear, and then through the middle ear we go through the round window, and the electrode is inserted into the cochlea through the round window. Technically, it's the scala tympani is what it goes into. Hearing therapy is critical. From your standpoint in pediatrics, postoperative management, infection avoidance, vaccination is the most important thing. And the key I would tell you is they need their typical pneumonia vaccines in the various forms that's taken over the past few years, but they also need the adult pneumovax vaccine after they're 2 years old. So you max out their vaccination for pneumococcus, and so that's the one thing. And you may actually have to send them to the health department. Most pediatricians' offices don't keep adult pneumonia vaccines readily available. Can't do monopolar cautery, but you can do bipolar cautery. So if this patient's having an appendectomy or some other surgical procedure, they have to be cautious with that because the cautery can adversely affect electrical circuitry. Magnet issues with MRI. They can have an MRI, but you have to remove the magnet. But it's getting more compatible with it, but it's still a little bit of an issue. So CT scanning is preferred for patients with cochlear implants over MRI. I've nearly not in children had much trouble with vertigo ever. Pain is usually minimal, and tinnitus, really haven't had complaints of that. The little girl that I showed in the picture earlier is actually an ETSU student now. My first cochlear implant patient, this is divine intervention. In 1999, met her in 98, implanted her in 99, went to Scott County High School, and she graduated valedictorian of her high school. So born deaf, valedictorian. Pretty cool. She's here at ETSU as a student in special ed right now. She's a junior, and I think she wants to do audiology. So pretty neat outcome. So these children can be highly successful academically if there aren't other developmental delays. Now early on we did not do implantation in children who had developmental delays because early on insurance companies were saying this is experimental, we're not going to approve it. Well, if we did a lot of children with developmental delays, then that would have affected the outcomes adversely and then would have reinforced the fact that some of these children didn't develop speech and maybe it didn't work. Once we proved to insurance companies that this was very successful, then the parents that had children with developmental delays made the argument, well, wouldn't my child be less developmentally delayed if they could hear? And the honest answer is yeah. And so unless it's a severely developmentally delayed child, most of those patients will implant now too, because if whatever their delay is, it's going to be improved by being able to access and hear sound. So they're mainstreamed at 2 times the rate of age-matched children, fewer hours of special ed, and a cost savings just up until senior year of high school as far as special education and sign language interpretation and different things, cost savings between $30,000 and $200,000. That's before they get out into the workforce. Think of what we spend on workforce for support of patients who have deafness or hearing loss, who can't get work or can't keep work, or welfare subsidies and that sort of thing. So it's a great benefit to these folks from an economic perspective. All right, so my time is going quickly, so let me move quickly. There's just 10 minutes left. So, all right, would y'all rather hear about Stridor or Baja? Let's go to Stridor, just to broaden the topic a little bit. Stridor is a high-pitched musical sound produced by turbulence of airflow through a partial obstruction in the larynx or proximal, or trachea or proximal bronchi. It needs a defined cause identified. It's the one thing I would highlight to you. Different types: inspiratory, expiratory, biphasic, acute, subacute, and chronic. The acute and subacute require a much more aggressive approach, obviously, than the chronic. Retraction, these are the signs that they're struggling more. Retractions of different varieties: alar flaring, dyspnea, tachypnea, anxiety, cyanosis. Anybody got a piece of paper that I can tear? All right. Y'all familiar with the Venturi principle? Anesthesiology folks are more familiar with this, but I'm going to just show you something that's kind of intriguing. So the Venturi principle, one would think if I had 2 pieces of paper and I held them flared apart and blew between them, you would think what? They would blow apart, right? You're blowing air through it, they should spread, right? Well, watch what happens. See that? That's the Venturi principle. So when airflow is high between mobile structures, it brings them together. Okay? So that's the problem with laryngomalacia and other things where you have pliability of the airway. Airflow increases. When a child is struggling to breathe harder and airflow increases, it pulls it together and closes the airway off more. So it's an important principle to understand when you're managing a child with croup or that has tracheomalacia especially, or a child that has a viral illness with laryngomalacia. Other sounds, stridor is more of a pharyngeal noise. I'm not going into wheezing, rhonchi, and rouse. I'll let your pulmonologist deal with that. Supraglottic location causes inspiratory stridor, and extrathoracic laryngeal or tracheal obstruction creates biphasic stridor, and intrathoracic creates expiratory stridor. Expiratory stridor is very similar to wheezing, hard to differentiate many times. So everybody know the difference in these? So inspiratory stridor is biphasic stridor is harder. I'll probably cough after I do it, but biphasic is so you're getting sounds going in and coming out. All right? So that's, everybody in pediatrics knows those sounds, but the medical students may not. Inspiratory stridor is happening here. Biphasic stridor is happening here, and expiratory stridor is happening here. So the character of the stridor should alert you to where the obstruction is. Stridor is more snoring, but it's kind of daytime snoring in the child that's sitting in your office awake. So that's the child that comes in is from adenoid enlargement, from allergies, from tongue base obstruction for whatever reason, from big tonsils. The progression or the onset is very important, whether they have apnea, cyanosis associated with it. Physical exam is important, auscultation. Most importantly, don't send these patients with acute stridor or significant obstruction to the radiology suite. You will have the code called after you do that. So if they need an x-ray, it needs to be done at the bedside in the ER. But don't send them to a place where they're not clinically observed. Not a lot of x-rays that help you a lot with this. The gold standard for evaluation of stridor is fiber optic laryngoscopy. It can be done in the bedside. It can be done awake. It's no different than the neonatologist or whomever, the nurse is putting in a feeding tube. Okay? Smaller than a feeding tube. All right? And we can see where it's going. A feeding tube is put in blindly. And you put in feeding tubes every day, right? Okay, well, a fiber optic exam, and you don't sedate anybody for feeding tubes, do you? No. So a fiber optic exam is just a feeding tube that you can see go in, all right? And we just get to look while it's going in, and it stops. We really stop at about the level of the tongue base. We don't even go down here. We stop about right here. We can see down here from the posterior pharynx. Less than 30 seconds usually, so it's pretty easy to do. Most important point here as far as causes of stridor in newborns, 60% of it's laryngomalacia. But here's the key point when you get out into practice. Don't assume it's laryngomalacia because 40% of the time you're wrong. All right? So it demands a diagnosis. All right? It needs to be, you need to know what it is. And you need to know what it is before the child gets croup so that you know what the baseline is so when they get croup or other problems you can adjust accordingly. Okay? So don't wait until you're backed in a corner with a major respiratory situation to figure out what you're dealing with the child with stridor. Croup, foreign bodies in older children, steroids, reflux medicine, and laryngoscopy are the keys. Reflux. My research and training was reflux. I did dual probe pH monitoring in children, did the largest first study of that. We have impedance monitoring now, but the key to remember is that if you have a mucosal injury, a cold, a viral illness with laryngitis, if you have an intubation, a child that's been intubated, if you have some, whatever the trauma, and you add reflux to it, you're going to multiply the problem, okay? So controlling reflux, even if it's temporarily, is really, really important in these kids. And so here's what I would tell you. They did, at Wake Forest, they did the first dual probe study on adults, and then I did the pediatric version of that. But it started with a canine model because dogs don't have basal acid production in their stomachs. Okay? They don't have gastric secretion baseline. But if you mock feed them and they see food, then they produce acid. So the study was done where they took dogs and they took a drill like we'd use for ear surgery and exposed the cricoid cartilage. Okay? So a laryngeal lesion, like being intubated chronically. And so laryngomalacia, let me show you a picture here. That's supraglottoplasty. That's the surgery we do for laryngomalacia. Tracheomalacia, laryngeal edema. Okay, so see this? This is cricoid erosion. The cricoid's the only complete ring in the airway, so it's usually the site, the most limiting factor as far as airway obstruction in the airway. So when a breathing tube's in there and it sits there for a long time, a lot of times it erodes the mucous membrane, erodes the perichondrium, and exposes the underlying cartilage. So they created this lesion in dogs and then mock fed them and then would paint on this area refluxate. They would mock feed them, go get their acid, and put it on there. And the dogs that had the acid added to it had almost complete subglottic stenosis. The dogs that didn't got better. So it just shows you reflux can be a huge impact on mucosal injuries in the airway. It's a subglottic stenosis, edema, subglottic stenosis above a tracheostomy tube. That white right there is a trach tube. These are the vocal folds. Suprastomal granuloma, that's a trach tube, and this is a granuloma above the trach tube. These are subglottic cysts. Bronchial stenosis, foreign bodies, a tooth, sunflower seed, peanut, piece of stick in the airway, crack cocaine vial. This was in Baltimore. I had to get Baltimore City Police to bring me a crack. I'd never seen a crack cocaine vial. I didn't know what I was going in to take out, but I just knew this patient had swallowed a crack cocaine vial. And so they brought me one, and so we got it out, but one of those interesting moments. Caustic ingestion, here's the burn on the abdomen, here's the burn around the lips, tongue swollen. Subglottic hemangioma is just a submucosal swelling but blocking the airway off. Then Pierrot band sequence, the tongue base. Medical students residents Pierrot band sequence is small jaw. Because of the small jaw, you get tongue base retrodisplacement. Because of the tongue base retrodisplacement during development, the palate doesn't develop, so you often get a U-shaped palatal cleft. But the tongue base pushing back in the small jaw leads to narrowing of the airway, and the epiglottis gets pushed against the back of the throat. All right, there's my stopping point. Those are my kids. That's a lot of information. I've got so much more. I'd love to talk with you all afternoon, but maybe a little hearing, a little stridor will give you some update in pediatric otolaryngology, and maybe I can come back another time and deal with some of the other subjects. But I'll stop there, take a minute or two of public questions, and then if anybody wants to talk to me afterwards, we can talk. But any questions I can answer for any of you.
When we do newborn hearing screens, oftentimes they refer 1 year or they refer both years, and then the nurse will say, oh, it wasn't a good test, let's do it again. And sometimes it's repeated multiple times to get a good test.
As long as they pass eventually, it's okay.
It's okay. So
Yeah, it could be technical error with the technician doing the test. It could be a number of things. But as long as they pass. But if they don't pass...
There's not a gold standard of it has to be within a couple of times or 3 times. And
Well, I think you reach a point where you say it's failed. Okay. So, I mean, what that right time is, I don't know that's defined. But I would say if you failed 2 or 3 times, probably best to move on to the next test rather than continue to repeat the previous screening test. Other questions?
you talked about behavioral testing for the younger ones. Do you ever go back and do what's done at birth, like do a screen like was done at birth?
We have an automated ABR, an algo test that we sometimes will do in the office, because the algo test will test the whole ear auditory pathway. whereas the OAE will just test the cochlea. So theoretically, you could have a pass on an OAE and have an auditory neuropathy because you're not testing the hearing nerve. So an OAE is not as complete a test as an ABR or an automated ABR. So yes, you could have an OAE will sometimes will miss a 30 dB hearing loss, so a very mild hearing loss. You have to have 35 or more decibel loss with an OAE for it to be abnormal. So it's not as good a screening test as an automated ABR is for newborn hearing screening. So I would say that. I don't know what y'all are using here at Niswonger, but most places are using automated ABRs, algo tests, instead of OAEs, although in the past OAEs have been used. It's just not quite as complete or good a test. But the vernix that you get in the ear canal from delivery can sometimes compromise that, and sometimes it takes a few days for that to clear out and actually get a screening test that passes.
And so that's the other thing we see is sometimes they will discharge the baby home, bring them back within a week, and to maybe get rid of the vernix. Is that a good sort of policy to do?
Sure, as long as they come back.
Mm-hmm. That's the key.
That's the key. Yeah. If they live 40 miles away and transportation's a problem, and then it falls through the cracks. So yeah, just the follow-up's key is having a process or protocol in place that makes sure you capture those kids, make sure you get them back so that they can be retested, or have a primary care community that's aware of those things.
And then if they pass the hearing test at birth, but have some of those risk factors, a family history of hearing loss or a NICU stay over 5 days, is there something that makes us want to retest them sooner than that 4-year mark that you would start?
Oh yeah, because they're in that other category that's high risk, so they actually get tested every 3 months.
Every 3 months.
Mm-hmm.
And so, and I don't know that automatically happens, that's why I'm bringing it up as sort of a knowledge. So sort of binds you to send them back to an audiologist to have that every 3 months. Okay.
I guess the one thing I would say here while you're in this institutional setting is you've got an audiology department. I've spoken to your audiology group up here. They are trying to grow, I think, that department, and so I think they would be an ideal place for y'all to get that done, or the otolaryngologists that are in town. Hopefully they have that capability as well. So should have a couple of different options. Residents, are y'all surviving? So, well, hang in there. It's a dynamic time. Eat and sleep when you can, and hopefully some of these talks will help you as you move on. So, thank you for having me, and good luck in your training.
Thank you.